Okay, so while a couple more people filter in, just a couple of housekeeping items that we always do at the beginning of our webinars. Want to thank everybody who works so hard to put on these webinars at the Neonatal Hemodynamics Research Center, as well as the Pan American Hemodynamics Collaborative. We also work closely with the special interest group through American Society of Echo and encourage everyone listening on the call to join that group as well. If you do have any questions, we will be having a wonderful panelist discussion with our invited speaker as well as with the audience after Dr. Al Saeed finishes his talk. If you could, please put your questions in the Q&A rather than in the chat box. We will be looking at them regularly in order to make sure that we get most of your questions answered. And without further ado, want to introduce my co-moderator, Dr. Zhu. This is her first time joining with us on this webinar in this type of esteemed position, and we're very excited to have her. She's a neonatologist at Mount Sinai in Toronto. She's also an assistant professor in pediatrics at the University of Toronto. She is one of our bright futures in terms of what her work is going to be in the clinical scientist development program. She's getting her master's in medical science at the University of Toronto and is going to be looking at cardiopulmonary phenotypes in preterm children. I'm very excited about the work that she has accomplished and that she's going to do. And for our talk, as you guys all know that have joined, we are going to hear from Dr. Al Saeed and learn more about the integrated evaluation of hemodynamics in the NICU. And now Dr. Zhu will introduce our panelists and our speaker.
Thank you, Dr. Ross. This is such a honor to be here to moderate this session. It is with great pleasure that I will be introducing Dr. Yasser Al Saeed, who is an associate professor in pediatrics at the University of Manitoba. He's also a staff neonatologist. He is an expert in echocardiography, as well as a researcher at the Children's Hospital Research Institute of Manitoba. He has also done a huge amount of work with POCUS and is the co-chair of the POCUS Neo group, as well as being part of the committee member who introduces neonatal echocardiography within the program for pediatricians in Canada. And we also have a wonderful panelist that includes Dr. Danielle Rios, who is an associate professor as well as a neonatologist at the University of Iowa. Dr. Rios completed her training in Texas Children's Hospital, and she's also a clinician, also completed a clinician scientist training program over there. And she's one of the neonatologists with experience in targeted neonatal echocardiography and has a particular focus in predictive analytics to improve the outcomes of extremely low birth weight infants. And from across the pond, we also have Dr. Marilena Savoia, who is a consultant neonatologist in Udine in Italy. And she has really developed her interest in neonatologists perform echocardiography in Sydney with Professor Evans, as well as her interest in pulmonary hypertension with Professor Abman in Denver. She leads the Italian training program in neonatologists to perform echocardiography, and she's also somebody who practices lung ultrasound in her clinical practice and works very closely with preterm-born children with BPD and follow them up in the clinic. And also we have Dr. Danielle Rios, who is a neonatologist from Mexico City. Dr. Rios is also somebody that we know very well in this setting, who is a president of the Neonatal Association of Mexico City and Valley of Mexico, and he coordinates a lot of the educational activities with neonatal hemodynamics as well as POCUS, and he has a research interest in the cardiopulmonary physiology and functional echo in preterm babies. So a wonderful panel of excellent people here today, and I will hand over the mic to Dr. Al Saeed, who will tell us more about the integrated evaluation of hemodynamics in the NICU.
Thank you very much, everyone. Thank you, Dr. Zhu and Dr. Arius for that kind introduction. It is my pleasure to be here today to talk about our experience in the integrated evaluation of hemodynamics in the neonatal intensive care unit. I have nothing to disclose in this presentation. And I would like first to start my presentation to send this presentation as owner a message to Dr. Regan Kissinger Sol. And we just say that we always remember your contribution and dedication to the science of the neonatal hemodynamics. And our condolences again to our colleagues at the University of Iowa. I have three main objectives in this presentation to discuss over the next 30 minutes or so. First, I will demonstrate the physiology of the integrated hemodynamics. Then I will demonstrate the main phenotypes of hemodynamic instability by relying on this integration. And then at the end, I will discuss some of the research studies that shown the impact of applying the integrated hemodynamics approach on the clinical outcomes. Before I start, I would like to show this slide just to go over the history of medicine in three eras. The first era, which was a long time ago, probably before graduation of all of us from medicine in the past, by relying on intuition in medicine and just the experience, the personal experience, just doing around every day, looking at the signs and symptoms, and everyone applying his own experience. And after that, in 1990s, the era of evidence-based medicine started with the clinical trials. And we started to respect everything coming from evidence as a standard. But we realized over time there is a lot of limitation by relying on clinical trials. As clinical trials assuming that every patient is the same, which is unfortunately is not the situation in all of the diseases. In hemodynamics, we believe more in precision in medicine and algorithms. That would be the future, which believe that every individual is different in phenotypes and in the hemodynamics background. That's why not everything we know in medicine can be subjected to clinical trials, including hemodynamics. It is complex, tough science, needs a lot of investigation, and it's very difficult to randomize the approach of hemodynamics into two equal arms. So first, what is the integrated evaluation of hemodynamics? Let us summarize that in three main points. It is integrating clinical biochemical monitoring parameters, whatever monitoring parameters available by technology, aiming to evaluate the factors that affect the oxygen delivery and the end organ performance, which led to formulating a targeted medical recommendation. If you understand from whatever we have biochemical monitoring parameters, from echocardiography, ultrasound, and from the end organ performance, the oxygen indices, now we can formulate targeted medical recommendation to restore adequate oxygen delivery and organ performance. And it might be really easier to understand that from this slide. So if we're talking about hemodynamics, we're talking about oxygen metabolism and the pathophysiology of hypoxia. So if you look at this slide, you can see whatever available in this slide, it matches most of the sick infants in NICU or any even intensive care. So there's two arms here, as you can see. And let me use laser. So you have either issue related to hypoxemia, and hypoxemia means that you have the cardiopulmonary compartment does not work well. That might be related to limited diffusion, right to left shunt, intrapulmonary right to left shunt, hypoventilation, pulmonary congestion, and pulmonary hypertension, which is not typically PPHN, it is pulmonary hypertension, while the wide range of phenotypes, and they will discuss that in different slides. VQ mismatch. And then hypoxia, which is definite low oxygen at the tissue level, which might be related to low blood flow due to low preload, low systemic vascular resistance, high afterload, poor myocardial performance, left-right shunt, or could be related to anemia. So if you are working in intensive care and you do round every day in the morning on sick patients, you may realize that at least one or two of the pathophysiologic issues related to hypoxemia or hypoxia present in that patient, sick patient. So if you're talking now about oxygen delivery, which include blood flow, so hemodynamics is not only blood flow, it is about the oxygen delivery and organ performance. About everything might maintain normal aerobic metabolism and normal functions of the end organ. So oxygen delivery, as you know, is a blood flow and oxygen content. And the blood flow is a stroke volume and heart rate. Oxygen content, including also hemoglobin and oxygen saturation. And the oxygen delivery should be enough to maintain aerobic metabolism. And we actually can get an idea about the function of the tissues by measuring the oxygen consumption. And then evaluate the organ performance by different techniques, including point-of-care ultrasound, for example, and perfusion at the end organ. And then the blood goes back to the heart to be loaded again with oxygen through the lung tissue. So the pulmonary system should be working well with the maintained ventilation perfusion matching. Adding more complexity to that, in neonates we have the shunts. So the shunt can be in either direction and actually might complicate things more. So integrated evaluation of hemodynamics, what I just presented, the introduction. I have now the integrated hemodynamics will be discussed briefly in 3 sections. The components of the integrated evaluation of hemodynamics, phenotypes of hemodynamic instability, and then the evidence that supports integrated evaluation of hemodynamics. Over time, we started probably 10 years ago with educating some of the neonatologists how to do echocardiography. And we thought that it is the hemodynamics concept to know how to do echo, which is not correct. And the concept changed from functional echo, focused echo. Now, target neonatal echo in Europe, they call it neonatologist performed echo. Whatever you call it, it is a technique. And the technique, you can just hire a technician to do it for you. It is not the hemodynamics. Hemodynamics to know exactly the comprehensive physiology and how to use the echocardiography parameters to understand underlying physiology. So if you learn a technique, that's good, but that's not the main thing. You need to know exactly how to use the technique properly to translate that into physiology. So the integrated evaluation of hemodynamics, echo is included, is one of the package, probably one of the most important parameters for now, maybe in the future might be replaced by a smaller machine like MRI at the bedside or different machine. But for our continuous monitoring of cardiac output, which is still at the research level, but for now we are using TN echo plus clinical evaluation of biochemical markers, monitoring of oxygenation. We are using now near-field spectroscopy. In our unit, it is a standard of care in sick infants for many years. Non-invasive evaluation of cardiac monitoring, like non-invasive cardiac output monitoring, or non-invasive blood pressure monitoring, invasive cardiac cardiovascular monitoring, like central venous pressure, or invasive blood pressure monitoring. You need to integrate whatever parameters at the end, as I mentioned before, formulate a medical recommendation based on the details that you are gaining from all of these detailed assessment. I will start first with the blood pressure. So we'll be talking about the blood pressure echocardiography and point-of-care ultrasound, near-field spectroscopy, and how to integrate between them. But the most important and maybe the simple parameter that we should have at the bedside, the blood pressure. And we still have a dilemma with the blood pressure. And until now, until 2023, do we as a neonatologist understand the blood pressure physiology and limitations? Probably a lot of neonatologists they understand, but still there's misunderstanding. And I will explain that in a next slide. The second question, do we have globally acceptable normative blood pressure values in preterm and term infant? during different stages of postnatal maturation? I guess the answer is no, and that might be a good question to discuss with our expert panelist after the presentation. The blood pressure physiology, we understand that the diastolic blood pressure reflects systemic vascular resistance and the blood volume, and the heart should contract on top of that to create another pressure, which is pulse pressure, not the systolic blood pressure. The pulse pressure, which is the pressure above the diastolic blood pressure, to eject the stroke volume out of the heart, which reflects pump action and also reflects the volume or the venous return to the heart. Both of them is systolic pressure. So one of the misconceptions by a lot of our colleagues that they are considering systolic pressure is the reflective pressure of systolic performance. It is actually the sum of both. It is a pulse pressure, not the systolic pressure. And still, a lot of our colleagues, they consider that mean blood pressure is equal to gestational age. It is a number that reflects 2/3 diastolic, 1/3 systolic, but does not really reflect exactly what's going on. So if we consider the two important independent parameters that reflect the hemodynamics would be diastolic blood pressure and pulse pressure. The others are still important, but these are the two most independent variables. That's why in our blood pressure centile values, we included pulse pressure, and the bedside nurse, she considered to assess the pulse pressure. If the pulse pressure narrow or wide, that reflects a physiologic meaning. And the previous table that we extracted from a study done in California in 1995 was based on non-invasive blood pressure monitoring, but it was a dilemma or issue that we don't have a normative value based on invasive blood pressure. We did that already. So it would be published probably within 2 weeks in pediatric research, already accepted for publication. This project we did over 5 years. Blood pressure normative values in preterm infant during postnatal transition. So we included, just to understand why we took 5 years, because the inclusion criteria was very strict. We included only babies born in the hospital, in the tertiary center, not outborn, and did not receive transfusion during the first 72 hours. Hemodynamically stable, did not receive any cardiovascular support, stable oxygenation, not in high respiratory support or high FiO2, not treated for hemodynamically significant PDA for the first 3 days of life, no significant IVH grade 3 or higher, and no early confirmed sepsis at the end survived to discharge. Now, the recruited infant study was 200 out of 500 plus. To get really normative data or reflect stable premature infants from 23 weeks to 28 weeks. And if you look at the curve, now you realize that every hour the blood pressure is different. It is going up from the 0 hour up to 72 hours of life. It's not a linear over the 3 days. So the blood pressure cannot be considered as linear or one number, like from birth up to postnatal transition period. Also for premature babies, it is not the same for 23 week or 24, 25, 26. It is actually increasing with increasing gestational age. So it's not that simple. And I'm actually talking about the first 72 hours, the most important period when you have most of the IVH might develop during that period. So we have the table that's now reflects the invasive blood pressure normative data for premature infants. Again, will be available soon on pediatric research, and it will be open access, which is one of the most important techniques, or the most sophisticated also techniques to evaluate hemodynamics. In this slide, I just try to summarize the parameters can be categorized into parameters related to left ventricle, which reflects systolic performance, diastolic filling or diastolic compliance of the heart. And then you can calculate cardiac output, systemic vascular resistance based on that. Right ventricle, also systolic performance, and then filling or diastolic compliance. And then the PDA shunt or any shunt can connect between both. And then you can categorize 5 categories of hemodynamic instability based on the echo: vasodilatory physiology, vasoconstrictor physiology, cardiac dysfunction, left-right shunt physiology, underfilling of the heart. And each one of them, there is a specific targeted treatment. We cannot just consider dobutamine or dopamine for everyone, blindly or empirically. So based on what you have from assessment of left ventricle, you have a good performance of the heart, good filling, but you have poor vascular tone, then it is vasodilatory physiology. You need to consider vasopressor. If it is vasoconstrictor physiology with impaired myocardial performance and high systemic vascular resistance, then you need to use entropy with vasodilator action. If you have cardiac dysfunction with poor vascular tone, both, then you need to use a medication working on both, like epinephrine and so on. Then if you combine cardiac output and blood pressure to get the systemic vascular resistance together, we can understand more about the variables. And here you have the mean blood pressure directly proportional to, not equal, the cardiac output as a surrogate marker for blood flow and systemic vascular resistance. If you have the systemic vascular resistance significantly dropped with a slight increase in the cardiac output, that's consistent vasodilatory physiology. If you have both opposite directions, the cardiac output decreased with increased systemic vascular resistance, in this situation, we have the mean blood pressure normal. And that's one of the main limitations of relying only on the mean blood pressure. In this situation, you have the vasoconstrictor physiology. If you have everything low, then you have severe or bad or late stage of cardiogenic shock. Now, we talked about the first part, but what about oxygen consumption? Well, now we are delivering normal oxygen. The oxygen delivery carried by the blood flow and with normal saturation, but we are not sure about the organ consuming normal oxygen or not. For that, we are relying on a new technology, which is not really new, but probably new to a lot of centers, which is near-field spectroscopy. In this slide, I try to summarize the concept of oxygen delivery consumption based on or how to benefit from using near-field spectroscopy for that. So we have three-dimensional graph. And just please, I need your attention with this graph because it's very important to understand the concept of oxygen delivery and consumption. So we have the lower x-axis here is oxygen delivery. It is ml of oxygen per kg per minute. And if it is more than 20, it is normal. If you are getting less delivery due to anemia or low oxygen saturation or low cardiac output, so you are getting less delivery. And you have also in the y-axis, you have oxygen consumption. It is normally between 5 to 9 ml per kg per minute. And it can be maintained even with the low oxygen delivery by increased extraction, which is upper x-axis. You have the extraction by percent. So the normal extraction is about 15 to 33% out of the delivery. That's why you have a lot of leftover oxygen reflected on the nearest machine. So the 70%, you have only 20-25% to consume, they have 70% left in the venous compartment. And then when the oxygen delivery decreased due to one of the factors here, you will get the extraction increased. And you will see that on a near-field spectroscopy as less number. You will see 60, 50, or even 40, and with increased extraction. So the tissues will try to extract more to compensate for the low delivery to maintain normal consumption. So low delivery, but extraction increased, but the consumption is still maintained in this area. Until you reach very low delivery less than 10 ml per kg per minute or single digit oxygen delivery. And these numbers based on animal and human research, including research in our unit, you will get the oxygen extraction reaching the maximum. The tissues cannot extract anymore. There is not enough to extract. Then you have the lactic acidosis. So there is not enough oxygen now for aerobic metabolism. The tissues will shift to anaerobic metabolism with lactic acidosis. So it is too late to see lactic acid in the blood gas. And at this time here, the extraction will be less, will be decreasing, and the near-field spectroscopy will be back to normal number, will not be helpful anymore. So here you have the area that the near-field spectroscopy might be helpful to you, but at the extreme here, when you have lactic acidosis, is not really helpful anymore. You have here area when you have normal oxygen delivery, but the extraction is very low. And this could be like, for example, in case of HIE, Like brain does not extract oxygen, although there is enough delivery because the organ is sick. Organ does not consume oxygen because of injury. Also, we are using near-field spectroscopy to understand the autoregulation, which is a black box for a lot of us for a long time. The autoregulation now is more understandable concept. In this graph here, you have the lower y-axis, which is the blood pressure fluctuation, or even the CO2, carbon dioxide, and you have the cerebral blood flow. Carbon dioxide and the blood pressure are the most two important factors that might impact the brain cerebral blood flow in sick neonate. So you have a plateau area here, which is any fluctuation will be associated with vasodilation or vasoconstriction to maintain the cerebral blood flow. But if the fluctuation beyond the range of the autoregulation, then the cerebral blood flow relationship will be more linear, will be decreasing or increasing, causing probably brain hemorrhage, like an IVH, for example, in premature infant. Unfortunately, in very premature infants early in life, the autoregulation curve is almost linear. There is very small range of autoregulation and usually matures beyond the postnatal transition and mature with more maturation, and the autoregulation curve will be more and more wider. And then at 1 year of age will be almost the same like adult. In this graph also, we can understand how the IVH, intraventricular hemorrhage, happened, when and why it happened. So that's part of our research not yet published. If we are monitoring by near-field spectroscopy, and we are not monitoring also carbon dioxide and hemoglobin every 6 hours in blood gases, and we are monitoring the blood pressure. So here the hemoglobin suddenly dropped. And at the same time, you can see the trend of the blue line, the trend of the cerebral oxygen saturation increased, which reflects reperfusion of the brain, sudden increase in the cerebral blood flow. That could be due to sudden increase in the CO2, carbon dioxide, or increase in the blood pressure, any one of them, or both in sometimes. So this reperfusion in premature infant might be associated with IVH that's confirmed by cranial ultrasound shortly after that. So typically, if you give me near-field spectroscopy, monitoring of the carbon dioxide, blood pressure monitoring, and blood gases, frequent blood gases to detect or monitor hemoglobin, I can tell you when and why the IVH happened in premature baby. Like to understand more about autoregulation, we have our own animal lab, which is a state-of-the-art integrated hemodynamics autoregulation research lab. We did a lot of research on to understand the hemodynamics in acute hypoxemic respiratory failure. And we validated also lung ultrasound in animal research. We are using piglet model, neonatal piglet model in our research lab. So the second part of the presentation now would be the phenotypes. So based on what we said before, everything should be within centile values. And we have the normal, diastolic blood pressure, and pulse pressure. Again, these are the most two important non-independent parameters for the blood pressure. They are maintained within the centile values, including PI, the perfusion index, which reflects the peripheral perfusion. And then you can detect that, you can get that from the pulse oximetry, systemic vascular resistance, and cardiac output, and cerebral oxygen saturation or tissue oxygen saturation. When you have vasodilatory shock, you have low diastolic blood pressure with normal pulse pressure, high perfusion index, low systemic vascular resistance, high cardiac output, and variable tissue oxygen saturation according to the degree of autoregulation or the degree of compensation. Vasoconstrictor physiology, you have high diastolic blood pressure, narrow or low pulse pressure, low perfusion index because of poor peripheral perfusion, high calculated systemic vascular resistance, low cardiac output, and variable tissue oxygen saturation. Cardiogenic shock, everything is low because it's advanced type of shock. Left-right shunt, you have low or lowish diastolic blood pressure, high or wide pulse pressure, high perfusion index, high cardiac output from the left side of the heart, low systemic vascular resistance, and low normal tissue oxygen saturation. And in volume depletion, you have normal diastolic blood pressure because of the compensation of the volume depletion will be associated with vasoconstriction, narrow pulse pressure, low normal perfusion index, cardiac output low, and high systemic vascular resistance, variable oxygen saturation. We just evaluated these centile values at 10 centile, 90 centile, and I appreciate Dr. Bakter McNamara. Sorry, he is sick today. He could not join us, but he contributed to our research significantly with significant support. And this is one of the articles that we did in collaboration with him. So we evaluated the centile values for end organ performance, saturation, including mesenteric, cerebral, and renal tissue oxygen saturation, calculation of the oxygen delivery, and also the cardiac output, systemic vascular resistance in stable premature infants. So we have the centile values as a stable, acceptable level for premature infants in this article. Also, we published what I have discussed already on this integration on most of the graphs that I showed in this article, the new physiologic-based integrated algorithm in the management of neonatal hemodynamic instability. And I have a case scenario, just maybe clarify how we can deal with challenging case scenarios using this integration. So you have a preterm infant, 25-weeker, 2 days old, with maternal preeclampsia. If you look at the blood pressure, 28/19, mean blood pressure might be acceptable for 25-weeker, but when we calculated the cardiac output and systemic vascular resistance was high. The normal systemic vascular resistance roughly between 150 to 200 millimeter mercury per liter per kg per minute. The ejection fraction shortening was low, perfusion index was low, and cerebral oxygen saturation was low, normal. And that's consistent with vasoconstrictor physiology. The echocardiography showed poor myocardial performance with negligible pericardial effusion, but this typical early vasoconstrictor physiology, if you wait more time, you'll see lactic acidosis. But typically, if you start medication early, that would be treated with just a low dose of dobutamine. In this case, I'm just showing how to integrate integrated hemodynamics with intestinal ultrasound in severe bowel ischemia. In this case, we have 29-week or 2 weeks old with presented with vasoconstrictor physiology or vasoconstrictor shock, lactic acidosis. But when we did intestinal ultrasound as part of our assessment, the entire intestine was globally ischemic. And this laparotomy done shortly after that showed significant ischemia for most of the bowel. And that was validated and detailed in the American Academy statement, clinical report, statement policy on point of care ultrasound use. And we clarified that intestinal ultrasound in neck or gut injury, it is superior. It is more sensitive and helpful if you know how to do that technique. If you are talking about pulmonary hypertension, so we should not use pulmonary hypertension as PBHM. Pulmonary hypertension is many phenotypes, which includes PBHM, which you may consider pulmonary vasodilator to treat with, and the priority also to optimize lung inflation. It could be with RV dysfunction. Then you have to consider medication to improve RV performance like dobutamine or merinone. But you may have also LV dysfunction with pulmonary venous hypertension. When you in this situation, but nitric oxide is contraindicated, you should not use it. Even if there's PDA, right to left shunt should be maintained open, sometimes with prostaglandin, and you need just to improve the heart performance by dobutamine or merinone. If you have biventricular dysfunction, you need to improve the performance before considering nitric oxide. You may have transient RV hypertrophy with low pulmonary blood flow, and this is typically seen in infants with premature closure of the PDA during delivery or shortly before birth. The algorithm to manage critically neonatal with hypoxemic respiratory failure or pulmonary hypertension as a framework, which is also considered as the policy of the Canadian Pediatric Society as a statement, was already published. And in our NeoPeds Academy, we used actually the same protocol as AI, artificial intelligence, to help you in the decision making. So it is integrating the oxygen, and this is, as you can see, pre-ductal saturation, post-ductal saturation, and so on, to get an idea about the oxygenation before you actually apply the echo values. And the echo values here just show you the list, exactly the same list as we described. So we have no pulmonary hypertension at all, or suspected critical congenital heart, pulmonary hypertension 2/3 systemic, pulmonary hypertension severe or moderate, and pulmonary hypertension with RV dysfunction, or pulmonary hypertension with systemic hypotension with LV dysfunction. So according to the pathophysiology, the artificial intelligence calculator will give you an idea about what you should consider next to avoid missing any information that might help in the decision making. At the end, you will have the formulated medical recommendation as, for example, here, adjust or a change mode of ventilation. Nitric oxide might be considered, and consider adjuvant vasodilator like Marinon. In this case, with assumed RV dysfunction. Integrating hemodynamics to lung ultrasound instead of relying on X-ray, again, to optimize lung inflation is very important before considering pulmonary vasodilator. X-ray is very limited, but you can get a good idea about lung ultrasound, which is now the standard of care in our unit and a lot of units to be used for evaluation of aeration and optimized ventilation. Lung ultrasound was respected by the American Academy of Pediatrics, again in the same clinical report, and highlighted that it is superior and more sensitive compared to the chest X-ray in most of the parenchymal lung diseases. Using integrated monitoring in HIE or any case of brain injury, how to integrate between brain activities, relying on ambulatory integrated EEG, near-field spectroscopy, Doppler, plus MRI and MRS, with respiratory assessment, and hemodynamics, as we discussed, how to integrate between near-ST and echo, invasive blood pressure, and you cannot separate between them. We are treating the infant as integrated relationship between all organs. We cannot actually separate heart from brain from lung. We have the neonatologist should understand all of the details related to the pathophysiologic mechanism of deterioration or. And then the evidence will be the last part of my presentation. So now we are talking about the impact of integrated evaluation of hemodynamics using target neonatal echo with indices of tissue oxygenation, including near-field spectroscopy and the clinical assessment. And to my knowledge, this was the first study to validate the value of using this integrated technique, including TN echo. So we applied this integration for 2 years, and we compared 2 epochs, the epoch after we started and the epoch before we started, which the era when before we consider target neonatal echo as a standard of care. And in this slide, you can see what happened. In epoch 1, before we implemented, we studied 340 cases with shock. I'm talking only about shock or systemic hypoperfusion. So first epoch, the time to clinical recovery was around 72 hours. And with 8 deaths, the epoch 2, we have almost half the time to clinical recovery with less number of deaths. The total number is not powered enough to study mortality in our patients, but you have at least less trend of deaths. And as you can see here in this survival curve, the Cox proportional hazards, you can see the green curve, which is epoch 2, ends early with less time to clinical recovery compared to epoch 1, which is the blue line. And we have also from the same study, much less improved cases of pulmonary hypertension with less need for nitric oxide, less need for medication, and less time to clinical recovery. And PD ligation significantly decreased to 0. So now we don't have PD ligation for almost last 5 years in our unit, and became an history. Also, I have to mention that use of higher dose of ibuprofen and acetaminophen as a backup medication contributed to that. But the PDA management is entirely neonatal decision now. Even the decision for PD ligation, if we are considering that still as a modality for or intervention. We also investigated the impact of integrated evaluation of hemodynamics management on late onset compromised systemic circulation in preterm infant. Preterm infant might develop hypotension, sometimes unexplained, it might be due to suprarenal dysfunction, not necessarily to be septic shock. Again, the time to clinical recovery much less when we consider the integrated approach, and the time or cardiovascular medication and the number of medication used much less. Before that, we were considering dopamine as a first line for everyone, followed by dobutamine as a second line for everyone. Now we have targeted management, and most cases just recover by one medication with shorter period of time and low dose. Also, I would like to highlight this app is available now on App Store. You can use it, which is Clinical Decision Support System for Integrated Hemodynamics. You can use the blood pressure centile values, integrated evaluation of hemodynamics, and you can enter the blood pressure values and can get an input about the limits that you may consider to wean medication if you're already started on cardiovascular support. And you have the echocardiography parameters that might help you with the decision making and calculate systemic vascular resistance for you. And also you can, if you have near field spectroscopy, can give you an idea about the total oxygen delivery, fraction oxygen extraction, and the important oxygen indices. You need just to enter the hemoglobin, oxygen saturation, and the number detected on near field spectroscopy, and also can give you the impression or the underlying physiology based on all of this information. You have, for example, here in this case, vasodilator physiology, and you have the expected causes or expected underlying causes for vasodilator physiology. So the physiology is not the same like cause. We should not consider vasodilator physiology as septic shock. Septic shock is a syndrome which could be vasodilatory physiology plus impaired filling, or could be vasoconstrictor physiology or late stage of cardiogenic shock. So the physiology is different. It is a unique one type of physiology, but the cause might be syndrome, might be different types of physiology at the same patient. That's why it is very important to apply a very detailed assessment and get much information and details as much as you can. I have three main conclusions. I started with three objectives and I end my presentation with three conclusions. First, understanding the physiology of hemodynamics is a crucial step for proper management of hemodynamic instability. Integrated clinical TN echo, point of care ultrasound, near field spectroscopy is helpful to formulate physiologic-based medical recommendation. And then integrated evaluation of hemodynamics is proven to shorten time to clinical recovery with less medications and interventions. I would like to thank you, all of you, for listening to my presentation, and happy to have your questions. And also, I would like to thank all of the panelists moderator for accepting to be available today. And I'm really interested to hear your experience and your input. I would like also to thank everyone in this slide contributed to our program, and or one of my colleagues or one of my fellows in the second row. Thank you very much again.
Okay, I'd like to invite our panelists and my co-moderator back to the screen. And thank you, Yasser, for that excellent presentation, which really helps to delineate the different physiologies that we are dealing with and give us some kind of real-time ways that we can help the babies in our unit. I would like to start off the conversation with something that's really important to me as a trainee in hemodynamics, who is just now kind of understanding a little bit more about what you've talked about. In your unit and or in units where you go and you teach others, what are some of the kind of first steps that you go through to help a unit change from kind of the older way of practice where it's DOPA for everybody or DOBUTA for everybody, and taking into account that maybe some units don't have the expertise that you have or don't have access to the imaging you have? What are kind of the on the ground basic steps that we can do to help take better care of the babies in front of us?
Thank you very much, Lauren, for wonderful question. That's a very important question, and I can summarize my experience when I started in our unit and about 10 years ago or more. And I can summarize that in few steps. and that might be considered to help our colleagues starting the same program in their units. The most important step to educate the team about the concept of hemodynamics as a physiology. So forget now about the T in echo, which is a really sophisticated part. And we are talking about the hemodynamics physiology. And the hemodynamics physiology, I started with the blood pressure. We were relying on mean blood pressure equal to gestational age, which has no any evidence to support. They're just assumption to make your life easy, or to make, like most of us, life easy for some time. But the blood pressure that we have, it is diastolic pulse pressure and the systolic. There is multiple variables available already in the monitor. We have to use them. So I started to teach about the basics of hemodynamics. I'm not talking about my colleagues, our fellows. I'm talking about the nurses at the bedside, talking about RTs. Now they used to look at the blood pressure in different way, and then it took some time for me to teach them. We have now the blood pressure centile values that we have to respect, and we need to look at that. And you need to report to the physician when you see any deviation from the normal values. You need to look at the trend. On the monitor, you have the trend values as a graph trend or as a number trend. So you need to look at the trend, not only one number at a certain time point. And that was a very important start to understand the basics of hemodynamics, the perfusion index, the near-field spectroscopy. After we started that, when we started with tissue oxygen saturation, we created educational program, and it was mandatory for all of the physicians, nurses, RTs to attend that educational online course on our learning management system. And then after we started to implement T in echo, we have written very clear, very clear triaging when the echo should be considered from the neonatologist responsible for T in echo, when the case should be referred to cardiologist. That was very important step at the beginning, and everyone respected that. And I did also educational sessions on every 6 months or 1 year to the nursing staff on the importance of using T in echo at the bedside, because it's consuming sometimes time. I'm coming at the bedside with a machine, and then they may ask what you are doing, what's the benefit of doing that. So they need to understand. So it took some time for everyone to buy in. It took maybe 1 year, 1 to 2 years to get everyone buy in the idea, and they have very clear vision about hemodynamics, and again include everyone in the unit. The technique itself, it is very difficult, comprehensive, and it should be only for a person who completed 1 year of training, as you know, and everyone knows. It is different from, for example, cardiac focus, which is totally different aspect. The T in echo should be performed by a certified trained person. And should be done in integration and collaboration with cardiologists, because in some situation we have to consult them, we have to include them in the decisions. And some, for example, refractory cases, pulmonary hypertension or so. So it is a kind of teamwork, including everyone in the unit. It took some time, but it worth it at the end. You change the life completely, how to manage the cases in your unit, and not only cases with hemodynamics issues, with hypoxemia, respiratory support. As I mentioned before, we are now integrating point of care ultrasound and oxygen indices. The last point, we started now making educational courses online on our learning management system, and that's open access to everyone in the unit. So they can get an access to understand more details even about all of these techniques.
Thank you for answering that question. As someone who's trying to start something in my own unit, at figuring out kind of where to start with so many changes that you may want to make in terms of approach to hemodynamics, because you learn so much, but recognizing that not everybody is quite there yet, and trying to teach the nurses and the RTs, I think that's a great step. One of the things that you brought up, and Marlena, maybe you can comment on this, and then we'll get to some of the audience questions, is point of care ultrasound, utilization of lung ultrasound. I know in the adult population now, echo techs do the cardiac echo, but they also do the lung ultrasound, and they're really now using this as more of a standard of care, and thinking about how much easier it is for us to do lung ultrasound in our tiny babies with translucent rims than it is for an adult Do you think that we should be doing this routinely now every time that we get a T and echo, or ask cardiology when they do an echo to go ahead and get that lung ultrasound too? Or do you think we're still in the research phase of bringing those two together?
Thank you. I will answer this question briefly. So lung ultrasound now is standard of care in a lot of units, including our unit. A lot of units in Europe, and probably another in 2 or 3 units in Canada. In US started to be also standard of care in some units. Lung ultrasound as also highlighted by the published statement from the American Academy of Pediatrics as a superior modality to X-ray and more detailed. It is easy to learn. It's not the same like echo. You need a team to implement the lung ultrasound to have 24/7 coverage. You need a team. And we reached that level of coverage when we started to educate our RTs, respiratory therapists. So we have in Winnipeg 30 RTs trained in lung ultrasound. They do lung ultrasound whenever indicated, not necessarily to be integrated with echo, but for any infant requiring higher support. I assume that if you have infant requiring more oxygen, you investigate for pulmonary hypertension, or also for lung parenchyma. You need to be sure that the lung is inflated well, optimized before you start a nitric oxide. Lung ultrasound is very helpful for that. If you are treating PDA and you need to understand the impact of PDA on lung ventilation perfusion ratio, you get an ID from the lung ultrasound, and optimized inflation of the lung will be helpful by literature to limit the shunt and help the success of the medication used. So it's very helpful to use it either integrated with the echo or in separation with any infant with any question mark issue with hypoxemia or ventilation. Again, it is easy to teach, or easy to learn. It is easy to implement, and there's anything, it takes some time because everyone used to look at the X-ray for decades, and that could be still the comfort zone for a lot of our colleagues. So it makes sense to take some time, but if you start strong program, you need to include a good number of practitioners, and again, education to everyone of the team, RT, nurses, and physician in the unit.
Yeah. I must say I totally agree with Yasser, and I strongly believe that lung ultrasound in 2023 should become standard of care for many reasons. The first of all is that it's very easy to use, it's easy to learn. I mean, at least from the technical point of view, it takes more time to integrate the data you picked up with the clinical picture, but it's something that has to be in the unit. I believe that lung ultrasound technique is following the path of targeted neonatal echocardiography. It started very slowly, and then it's spread all over the world. In our unit, we've been using both techniques, lung ultrasound and functional echocardiography, for the last, I believe, at least 10 years. And what we do now is when you have, instead, many years ago, you would think about performing a chest X-ray. Now, what you do is to perform straight away a lung ultrasound. It takes only a couple of minutes. And it gives you, as Yasser said, a lot of more detailed information rather than chest X-ray. Moreover, when we perform a functional echocardiography, we do perform straight after that a lung ultrasound, because we believe that heart and lung interactions are very, you need to investigate the heart and lung interactions that are always there. more or less, depending on the disease. And from the training point of view, as we said, lung ultrasound is very easy to learn. In a unit, every clinician should be able to use it. It's not difficult to learn. Of course, a clinician should practice every day to get confident with this technique. But what we found, it was that the nurses ask you to perform a lung ultrasound. I must admit, we didn't perform such a good teaching to the nursing staff and as Yasser did, but each time we do perform a lung ultrasound, we would spend a bit of more time showing on the machine, not while you are picking up the pictures, but in the machine, we would spend time explaining to nurses what we've done, what we found. And we got to the point that the nurses ask us, please do perform a lung ultrasound, see what's going on, because they know that it's easy, quick. And from the functional echocardiography, only few of us has the expertise to perform a comprehensive echocardiography, so a comprehensive evaluation. But each of us in the unit learn how to perform a couple of emergency diagnostic procedures, such as looking at the tamponade, such as looking at the heart ventricular contractility, and so on. So I totally agree with Yasser, and I'm a big fan of lung ultrasound and TNE done together. And yes, the integration we do is it's always with lung ultrasound and TNE, but it's very, very interesting what Yasser said about, for example, a simple perfusion index that usually, in my opinion, in the units is underestimated.
Thank you very much. Wonderful. I really appreciate your comment, Dr. Sfoy, about lung ultrasound. I have to acknowledge that lung ultrasound actually started in Europe, in Italy and France, by our friends Francesco and Daniel De Luca, and it's our pleasure to attend the lung ultrasound annual conference. This year will be in Milan, so we invite everyone to come and enjoy the beautiful city of Milan, and hope to see you there. I'm really also interested to hear from the other panelists, Dr. Daniel and Dr. Daniel. You have the same name.
Yeah, one thing that has been pointed out that I think is really interesting is that when you start a program, the integrated part of it, it's what makes it a potential to be a successful one. So it's really important, as Yasser said, to involve everyone around, because it's not just you getting into the NICU with a sophisticated technique, it's you integrating ultrasound as a tool to get more information about the patient. As we've seen, single values or single techniques are not as potent to give us a clear picture of what's the physiology of the baby. So you might have a normal ejection fraction, you might have, but it's not all, right? You need to do a complete and comprehensive evaluation of the patient, and a lot of the vital signs that you would hope to find it different, they might be normal, or the baby might be compensating. So I think the way to go is to present it as a part of an integral program where ultrasound makes you a better clinician. That's what I think that it's really important to know, that it's just extra information, but it makes you a better clinician. It does not takes you away from the baby. It makes you to be more careful to take into account all of what's happening to the patient. So the integral part of the integrated, every ultrasound program needs to be an integrated program with and that makes it easier to implement in the NICU. So in Mexico, it's sort of the same now that we're having this discussion about what's TN echo and what's point of care cardiac ultrasound. So we've done it sort of the same. We think that the main competence, we think every neonatologist should be able to do a complete lung ultrasound. Like lung ultrasound should be our tool. It's like our new fancy stethoscope, but it's amazing the amount of information we have. And then we need to have people properly trained in targeted neonatal echo to do the hemodynamic consultation, but it's a continuous of imaging. So it's a team. And I think I really admire Jasser and his work. And when I read the article of the RTs doing the lung ultrasound, their lung ultrasound program driven by the respiratory techs, that's amazing. That's the way to go. But as I said, single echocardiographic or ultrasonographic measures are not the whole picture. You need to take into account a lot of factors. And when you do, and when you take everything, what you need to do is identify different phenotypes, creating good definitions and frameworks. And that's how we can move on, specifically in hemodynamics, that as Yasser said, we won't have the perfect clinical trial with the same baseline condition to see if something works or doesn't.
Yeah, very good. Thank you very much.
And
Yeah, go ahead.
Oh, yeah, Carolina.
If I may say, when you perform a functional echocardiography, everybody would tell you to be systematic, to have a clear method and repeat it each time you perform it. The same thing has to be done with the lung ultrasound. You cannot jump from one side to another. You need to be systematic, to have an order in your evaluation. Otherwise, you would get confused and mainly miss things. So perhaps get a misdiagnosis. So.
Thank you very much.
And to invite Danielle to the conversation. I know that her webcam isn't working. Danielle, I know that we've talked a little bit about bringing lung ultrasound into the NICU, but I know for the most part, it's serial targeted neonatal echo. Kind of what are your thoughts on how it's been kind of building that program here? And then do you think that adding lung ultrasound is something that you guys are looking to do in the future?
Thank you, Lauren. Yeah, so I think that I agree with you guys all completely. And one of the things that we've noticed that has helped us integrate the program more into the NICU was educating the nurses and the RTs to these things. So we have a special ongoing nursing hemodynamics kind of informational session that they love. And we only invited a small group of them to begin with, and then they were kind of going to be the super users type of process to then be able to teach their colleagues during their shifts. And we actually had a lot of nurses just very upset that they couldn't also join in. And so we've opened it up to a lot more of them. And funny, you should also mention adding in lung ultrasound is we're going to have Marilena come and teach us a little bit more about that soon. And Patrick's kind of ideal situation would be having us be able to perform the hemodynamics consult with the addition of the lung ultrasound to really be able to understand the physiology, both in the cardiac sense and the respiratory sense as they're married.
Very good. I would like to comment quickly on important thing that I'm sure that if Patrick is here today, will comment on that. how to differentiate or how to distinguish between the cardiac point of care ultrasound performed by someone trained in point of care from TNECO, which is more detailed assessment and more detailed training. Yeah, I agree with Marilena that using point of care ultrasound as emergency tool for assessment of the heart failing or cardiac tamponade, there's pericardial effusion. We summarize that in the American Academy of Pediatrics statement about 4 conditions that can be considered for point of care ultrasound for quick assessment. Infant who is really suffering from severe hypoxemia, and probably the person of doing the TNECO was not available. So you may assess the heart to understand the heart and lung to see if the heart showing severe pulmonary hypertension was significant dilated right ventricle, and the lung is not the main reason, or vice versa. Or there is cardiac tamponade or cardioplegia. So the heart does not contract. You need to give unit troops. Or there's underfilling. You need to give fluids. These are the 4 conditions summarized in infant who is crashing. We're talking an infant who is crashing or crashed, and there is not enough time to get someone expert in TNECO to perform a detailed functional echo. And you can rely on someone who is really trained on point of care ultrasound. And recently, Patrick and Amish published a nice article to differentiate clearly between cardiac POCUS and TNECO. It was a really interesting article. And again, it's very important to remind everyone that don't mix between both. Don't consider assessment, detailed assessment for someone with shock or PDA or ongoing pulmonary hypertension, not very sick, through cardiac POCUS. You need someone really expert in TNECO.
I can speak a little bit to that too. So I do targeted neonatal echo, but haven't graduated yet. And so still have to have cardiology and the echo techs help me and review all my images, which they probably will do once I'm done as well. But I've also done some cardiac POCUS, especially at night, because at night I don't have access to the echo machine and we don't routinely call people in. And so what I've learned from that experience is that in the truly crashing infant where I was going to fly blind and try something blind anyways, right? I was either going to try nitric or I was going to try an inotrope, or I was going to go up on my vent settings just based on a gut feeling. Cardiac POCUS helps me a little bit by seeing if, you know, the ventricles aren't moving at all, or if one side of the heart is huge, or if looking for a malpositioned line and always looking for signs of tamponade. I will say one of the things that I've seen with this though is how much I can miss with cardiac POCUS and how much I wish I could actually go grab the TNECO machine to try to have a better understanding of what are actually the cardiac outputs. How are they different? What is the PDA actually doing? Because while I have a good cardiac POCUS machine, the images aren't as good as the echo machine. The functionality is not as good as the echo machine. And so while I feel like I'm flying a little less blind than I was before, where I wouldn't look at anything and I would just try things and then try other things. I'm still trying things and trying other things, but now have something to give me a little bit of guidance, and I can have another tool that I can use to say, am I getting worse or getting better? But I still really miss that targeted neonatal echo. And so it's taught me kind of how lucky I am now to have learned some of that skill, and how important it is to not miss some of those things and to understand what you're looking at. And hopefully what I'm going to be teaching my POCUS users, and have done a lot of kind of groundwork with them, is that we are not teaching targeted neonatal echo. We are teaching cardiac POCUS, and targeted neonatal echo is a very different animal. But me doing both of them, I think, is giving at least me some perspective on what can I actually do with cardiac POCUS versus what can I not do with cardiac POCUS, and hopefully understanding a little bit more of the limitations and advantages of both. And Danielle, I can kind of see you moving around. I know that you've done targeting echo as well in your training, but I also know that you have some experience with cardiac POCUS. How have you been able to integrate those two, or just one of them, in the different units you've been in?
So what we basically did is we tried to teach our fellows with long ultrasound as a general competence, as Marielena said, with the whole structure, with the whole systematic way to do it. Now we have a national team, so we're trying to do our Mexican standards for once the technique is spreading around the Republic, so everyone does it the same and we speak the same language. And when we do our long ultrasound workshops, we adapted three algorithms: the SAFE algorithm from Nadia Youssef, with some algorithm from Rodriguez Fanjul when you have a cardiac arrest, and also an algorithm that Ashraf and Amish did when you have an infant collapsing and the baby has a central line. So it's basically Nadia's SAFE approach. So where you do basic cardiac focus. So you see if the baby is, if you have contractility issues, and you call cardiology, or you call hemodynamic consultation, or you have underfilling, just as Yasser said. So basic things: underfilling, the heart is not contracting, and all the way you need to suspect a congenital heart disease, right? And then for long ultrasound, you go right away to see if there's lung sliding, if there are pneumothorax you need to resolve, or you have a big pleural effusion. So it's a really basic algorithm where you can detect these things. And the experience we had was that we had it in 25 crashing infants, but in 5 of them, the fellow on call resolved tension pneumothorax and tamponades. So it's and the advantage is that something that they might do blindly, now they are seeing what they're doing. So that's the way we integrated both. But that's how we've been doing. It's we only teach long axis, subcostal long axis, and a 4-chamber view as cardiac focus, and the full long ultrasound approach.
Yeah, I was going to say, I think it's a really important point that there's, what do you do as a standard of care, and then what do you do in an emergency? And we all do different things in emergencies, and not being handcuffed to not being able to look at the heart. I was in that experience too, where I didn't ever look at the heart, even though I thought, well, maybe it is tamponade if I could just put the probe there and see. And so I think teaching people how to do that, but also, as everyone on this call has already said so eloquently, making sure that while we teach people how they can look at things, we also, even more importantly, teach them what they can miss. The importance of getting a full echo to make sure there's not congenital heart disease, the importance of getting a hemodynamics targeted neonatal echo as soon as one is able to get that, but still at the night arming our colleagues with the ability to do some sort of assessment in a baby who is acutely dying. And I want to bring it to Faith now, because I know that there's been a question that has come up multiple times in our audience chat that we haven't had a chance to go through.
So I think probably along the lines of what many people have talked about in the situation of assessment of a baby. There have been a few questions from our attendees asking really about SVR. So maybe I'll direct this first to Daniel in terms of how would you assess SVR, and what is your method or your way of processing that as you're looking at a baby's hemodynamic status?
So what we do normally, we look at the different parameters of blood pressure: systolic, diastolic, and pulse pressure. And to have a calculation for SVRs, we actually use Yasser's calculator. So I think Yasser can answer it better.
Yeah, thank you very much, Daniel. So we simplified, as Daniel said. We have now the online calculator. We have mini calculators actually. If you go to newbeats.academy website, there is available calculators available for free. Anyone can use them. There is one is integrated hemodynamics, simple one that you can use it to calculate the systemic vascular resistance. Also, there is more detailed clinical decision support system, which we recently made it as app available on App Store. What you need to enter, you need to enter the blood pressure and the cardiac output. If you'd like to calculate it simply, you need the mean blood pressure divided by left ventricle cardiac output, if you're using the left ventricle cardiac output as a surrogate marker for systemic blood flow, if there is left-right PDA shunt significant, then the left cardiac output reflects the pulmonary circulation, not the systemic. Then you need to use the RV output as a surrogate marker for systemic blood flow. If you have left to right significant shunt through the PDA. Convert the output from ml per kg per minute into liter per kg per minute. So for example, if you have 150 ml per kg per minute divided by 1000 is 0.15 liter, 0.15 liter. And you have the mean blood pressure divided by 0.15, you get the number. Normally it's between 150 to 250 ml per liter per kg per minute. It's a little bit long, but that's a detailed, non-invasive. It is non-invasive indirect way of assessment of systemic vascular resistance. Typically, the most gold standard way is the invasive method. But that's very difficult to do that on a clinical basis. So if you remember the equation, you can do it. If you struggle to remember the equation, the app is available. You can just enter the blood pressure and cardiac output, and you will get the results. And also you get the impression, is it high or low? So even based on the centile values that we published, you'll get, is it acceptable, high or low? So your life is much easier now.
And in our case, as it's only an estimate, but it gives you a lot of light. A lot of times when you go and do the hemodynamic consultation, the team has already started medication. And especially when you have a vasoconstrictive physiology, you use the calculator and you find that there are different elements that you need to be taken into account, and it allows you to go down with the medication.
Yeah, definitely.
No, that's great. Any last comments from our panelists, our speaker, and my wonderful co-moderator before we wrap up this exciting session?
I have actually, I recognize an important question from probably one of the colleagues asking about the training. If they would like to start hemodynamics program and they have only pediatric cardiologist, can they rely on training through pediatric cardiology to start hemodynamics program? The short answer of that, only our colleagues from pediatric cardiology can help in the echo training part, which is the technique part. As I mentioned before, that's not the most important part. The most important part is the hemodynamics concept and science. As a physiology, you need to get that from someone expert in neonatal hemodynamics, already trained in hemodynamics. So that only can help, like the availability of pediatric, supportive pediatric cardiologists can help in the echo, but not the hemodynamics physiology concept.
If I may add to what Yasser said, I totally agree with him. And what we are doing now in our unit, where we are training other colleagues to perform functional echocardiography. And we organized the training lasting 1 year. And those who are teaching, the colleagues are our pediatric cardiologist and me as a functional echocardiographer. We rely on the pediatric cardiologist for the anatomical description, you know, how to perform an echocardiography. From, let's say, to perform the first comprehensive echocardiography, the first one, where you need to check all the elements, the anatomical elements. And the part that is dealing with the functional assessment is done by the neonatologist. So I totally agree with Yasser about what he said.
Yeah, thank
you. So the pediatric cardiologist is very helpful, but not only it has, in my opinion, to be involved, because you work as a team. The team is not only very important for the integrated hemodynamics, but also for the unit, the hospital. You need to work with your pediatric cardiologist. also because you start speaking the same language.
Well, I hate to cut this short because I know that we could talk about this exciting topic for another hour or so, but want to, be respectful of everybody who's taken so much time, not just our speaker and our panelists and my co-moderator, but those of you in the audience who have stayed with us during this talk. We will do our best to answer your questions at a later date and be able to provide them to you on our Twitter feed. And again, thank you so much, Yasser, for putting together this talk and talking to us about your immense experience, and to Danielle and Marilena and Faith. Thank you guys for joining us today. And just a quick apology from Patrick McNamara. He is sorry that he wasn't able to be here with everybody, especially for one of our webinars, but especially for a webinar of such an important topic. So thank you all again in the audience for joining us, and we will see you next time.
Thank you, everyone. Thank you.
Thank you.
Thank you.
Thank you.